All right. Sarah, do you want to go ahead and share your slides? I am so excited about our grand rounds today, and I know that we will have tons of questions. So I want to make sure we have plenty of time for that. Great. Cameras are great. Okay. You guys ready to get started? All right, we'll do it. Thank you all so much for being here today. As I mentioned before, in the interest of time, because I know that we will have plenty of questions and discussion for our presenters, I want to go ahead and get started. Today, we are so fortunate to have two of our faculty endocrinologists speaking to us today. Sarah Markley Webster will start. She completed her undergraduate education at UCLA, medical school at Baylor, and then we were lucky to recruit her to Emory for internal medicine residency, where she stayed for endocrinology fellowship and then stayed on as faculty based at the VA. She is primarily interested in medical education, including improving endocrine knowledge within the residency program and using small group education in place of didactics for more focused teaching. She also works to use OSCEs to provide additional training on the less tangible but very important parts of medicine, like setting an agenda, shared decision making, and breaking bad news. In her non-work time, she shares two small kids, although growing quickly, with one giant dog and her ID attending husband, all of whom keep her busy. She is going to be sharing this presentation alongside Alexandra Migdal. Dr. Migdal completed her undergraduate med ed at Emory University before going to Beth Israel for internal medicine residency. She stayed there for endocrinology fellowship at the combined Beth Israel Joslin Diabetes Center program. And while she was there, she worked in the Murados Flyer Lab, studying the induction of fibroblast growth factor 21, which is a hormone responsible for the regulation of many metabolic pathways and implicated in obesity and MASLD. And that was formerly, or metabolic dysfunction associated steatotic liver disease. I wrote a note about it, which for people like me is the condition formerly known as NAFLD. She specializes in obesity and metabolism, specifically as it relates to an individual risk for development of complications secondary to obesity, including type 2 diabetes and MASH, formerly NASH. She has recently been awarded a Research Development Award to use AI applied to VA datasets to develop a novel strategy to identify veterans with MASH associated liver fibrosis and explore screening strategies to identify patients at risk. Outside of work, she enjoys spending time with her daughter and two crazy rescue dogs. Thank you both for such wonderful bios. And thank you for being here. Today, they're going to talk to us about how the tides have turned our clinical practice upside down, an update on GLP-1 receptor antagonists in diabetes, obesity, and beyond. And again, like I mentioned, please put your questions in the chat so we can make sure we get to as many of them as possible. And I will hand the mic to you, Dr. Markley Webster.
Thanks, Dr. Law. All right, so I have no disclosures, and Kimberly asked us to include a blurb about how we ended up here and in endocrine. And so my blurb is, I have wanted to be an endocrinologist literally my entire life. It's what I've told people since I was 4 years old. My mom is a very sensitive type 1 with frequent hypoglycemia. And so I've been dealing with type 1 for a very long time. And it was a happy day when I realized I could not only be an endocrinologist, but a teacher. And so then I ended up here and doing endocrine and in med ed. And then Dr. Migdal.
So I don't have any life-saving stories to share about, but I really became interested in endocrinology because of the love of the physiology, and talking through the kind of feedback loops. It just kind of makes sense. You can put the puzzle pieces together. And incidentally, my dog does have adrenal insufficiency and was diagnosed after she presented with an adrenal crisis. So in some ways, I think that was meant to be.
All right, and so learning objectives today are to really think about how we use GLP-1s and in which patients. So patients with not only with diabetes, but obesity, ASCVD, CKD, MASLD, because I'm not saying that mouthful, OSA, and substance abuse disorder, plus some of the other medical conditions that we're using them in. And so I wanted to start with a case that I think many of us have seen. So Mr. Snickers is a 62-year-old gentleman with past medical history of hypertension, hyperlipidemia, prior MI status post-stenting, CKD3A, and COPD, who was admitted with pneumonia. During his admission, we diagnosed him with type 2 diabetes with sugars running in the 200s and an A1C of 8.2. He's also noted to have a BMI of 32. We treated him with basal bolus and corrective insulin while he was here. He also saw the nutritionist and the diabetes educator, and he's ready to go. And we're thinking about, what do we send him on? And there's a lot of confusion around diabetes management, because for many of us who aren't in the endocrine field, it feels like every time you turn around, there's a new drug or a new indication or something else that has come out. And how do you keep track? And a lot of this has come from, initially all we had was insulin. And for about 30 years, it was just insulin. And then we got a few more drugs. We got sulfonylureas and metformin. And for the next 40 years, this is what most of us were using, right? Insulin, sulfonylureas, metformin, including when I started training at Grady, this was like the majority of what we had. And then in the early 2000s, we got better insulin. About 20 years ago, we got our first GLP-1 and our DPP-4 inhibitors. And then over the past 15 years, diabetes has really exploded. We got a whole bunch of GLP-1s. We got our SGLT2 inhibitors, inhaled insulin, concentrated insulins. In 2022, we got our first dual agonist, GIP and GLP-1 receptor agonist combo. And next year, it's expected we'll have a triple agonist, GIP, GLP-1 glucagon receptor agonist. And so it makes it really hard to keep up with what's happening in diabetes. The other reason diabetes has become challenging is because we've shifted from a glucose-centric model, and this is the model that I learned in residency here back in 2015, to a patient-centric model. This is the ADA Standards of Care 2024, and it's really busy. But what it's trying to boil down to is, what else does your patient have? Or kind of, how can we kill two birds with one stone? Does your patient also have ASCVD, or are they high risk of ASCVD? Do they have heart failure? Do they have CKD? Or do they have a goal of weight management or weight loss that we should be focusing on? And so can we pick medications that are addressing multiple aspects, not just the diabetes anymore? And lastly, once we've got the drugs, we have to think about the medications for diabetes. There are so many different organs and therapeutic targets for these medications, which makes it additionally hard to keep them straight and remember which benefits we have. So we're going to be focusing on the class of incretins today, the GLP-1 receptor agonist. And so we only have a handful that we have to think about. And I want to focus really on liraglutide, dulaglutide, and semaglutide, because these are the ones that have additional benefits beyond weight loss and diabetes management. So they also have ASCVD benefits that some of our others don't have. The liraglutide and semaglutide come in pens just like our insulin do, with needles that screw on. Dulaglutide comes in an injector where the needle's hidden, so this can actually be really useful for patients who have needle phobias and don't want to see the needle. And then I have further bolded and underlined semaglutide because, in addition to having the ASCVD benefits, it also has renal benefits and is really the most effective medication in this class. So if you're thinking about GLP-1s, you really want to think about these three. And if you can get semaglutide, it's going to be the most effective. So how do these GLP-1s actually work? So if we're talking in regards to diabetes and glucose management, they act on our pancreas to stimulate insulin secretion in the presence of food. And so this really reduces our risk of hypoglycemia. No food, no insulin. They also help preserve beta cells and prevent beta cell death, which has some research implications for early type 1 patients who are maybe in the honeymoon phase and still have active beta cells. It also acts on our muscle to increase insulin sensitivity and glucose uptake, and on the liver to decrease gluconeogenesis or glucose production. And acting on all three of these organs is how we lower glucose and improve our A1C. From a weight perspective, we act centrally directly on the brain to promote satiety or fullness. We act on our GI tract, on our stomach, to slow gastric emptying, so we stay full longer, causes like a functional gastroparesis. And then it acts directly on the fat to increase lipolysis and decrease fat mass. So these three things together combine to contribute to the weight loss that we see with the GLP-1s. And then lastly, we do have some direct benefits on the heart. All of the ASCVD benefits aren't just because we're improving diabetes and we're improving weight. They do improve cardiac glucose utilization, and they reduce inflammation in the vessels around the heart. So they do have some direct cardiac benefits as well. So we're going to go through these benefits in depth, right? The A1C reduction, like we've talked about, without the risk of hypoglycemia, the weight loss, the ASCVD risk reduction, and the kidney protection. And so when we're talking about A1C reduction, again, we're really talking about semaglutide, dulaglutide, and liraglutide kind of heading the pack of the GLP-1s, with this A1C reduction of about 1% for dulaglutide and liraglutide, about 1.5% for semaglutide. And that's compared with some of the other GLP-1s like exenatide, which Grady used to have, which had A1C reduction of about 0.8, was much weaker. We also have tirzepatide, which we're going to talk about a little later in this talk, but I wanted to point it out here as it has the most potent A1C reduction at 2.1%. This is our dual agonist. And retatrutide is our triple agonist, and it's kind of middle of the pack with our strongest GLP-1. And so how does this compare with the effectiveness of other diabetes agents? And so semaglutide either matches or beats nearly all of our other medications at about 1.5% A1C reduction. The only things that get close are really metformin and sulfonylureas. So not only do these have other benefits in terms of heart and kidney, but they're one of the most effective medications we have aside from insulin for diabetes. And so if we come back to Mr. Snickers and we think about, well, he's had an MI before and he's had stenting before. So let's talk about GLP-1s and cardiovascular disease. And so this is a meta-analysis from a couple years ago, and it looked at 3-point MACE. So cardiovascular death, non-fatal heart attack, non-fatal stroke. And if you look at LEADER, which is liraglutide, SUSTAIN, which is semaglutide, and REWIND, which is dulaglutide, these are the 3 studies that really contribute to our knowledge that GLP-1s are associated with reduced risk of MACE. And so you can see again, it's semaglutide more than the other 2. Semaglutide gives me about 26% risk reduction of MACE, compared with 12 to 13% for liraglutide and dulaglutide. So not only is semaglutide the most powerful GLP-1 for reducing A1C, it's also the most powerful GLP-1 for reducing ASCVD risk. And then again, if we come back to Mr. Snickers and we look at a different comorbidity that he's got, let's talk about his obesity. And can we use a GLP-1 to focus on his obesity? And again, my focus here is for semaglutide, you're seeing anywhere between this 10 to 15% weight loss compared with baseline, as opposed to my other GLP-1s, where I'm seeing more along the lines of 5 to 10% weight loss. And so GLP-1s are really powerful agents for weight loss. We think about some of our older medications giving us 3 to 5% weight loss, and we were really happy with that. Now I can get 15% with a once-a-week drug. This is huge. And so when you're talking to patients and you're getting these started, you want to warn them about the weight loss, but it's going to plateau. So they're not going to keep losing weight forever and withering away. They're going to plateau after about 3 to 6 months, and they'll level out. Now, with every dose escalation, they're going to lose a little bit more, but they will plateau, and it's usually 3 to 6 months. Now, again, back to Mr. Snickers, who has a third comorbidity that we might be able to help. He's got CKD3A. And so initially, when we looked at GLP-1s and we thought about chronic kidney disease, we looked at the development of this composite kidney outcome, which was the development of albuminuria, a decline in GFR, progression to ESRD, or death related to kidney disease. And we said, oh, great, there's benefit here. And again, it was liraglutide, semaglutide, and dulaglutide that really contributed to that benefit. But when we looked more closely, we saw that it didn't really prevent progression of CKD. It didn't stop worsening of kidney function. All this composite outcome benefit was mostly driven by the reduction in albuminuria. So we could decrease albuminuria, but we weren't changing outcomes until this year. And so a new study called FLOW came out just a couple months ago, which looked at semaglutide, and it looked for a longer duration. And what we saw was they actually do reduce kidney outcomes. So this study, major kidney disease events were defined as the development of kidney failure, which was starting dialysis, getting a kidney transplant or GFR less than 15, or 50% reduction in GFR, or death from kidney or cardiovascular causes. We found we have a 24% reduction, but we hadn't looked long enough. So this is months, not weeks. And so most of our studies in GLP-1s for kidney disease had looked for weeks, 6 weeks up to maybe 12 or 6 months up to 12 months. And we don't start to see these lines diverge really up until closer to kind of 18, 24 months. So it takes much longer to see the benefits of GLP-1s on CKD, but they are renal protective. It's just not going to be as rapid as we think about with our SGLT2 inhibitors. Now, adverse effects, right? What do we warn patients to keep an eye out for? And you may have all seen news articles about things like Ozempic face, Ozempic butt, stomach paralysis developing from Ozempic, and may have had patients reaching out to you about these. But really, the most common side effects are all GI related, which makes a lot of sense given their mechanism of action in slowing the GI tract down. And so diarrhea, nausea, vomiting, these are the main side effects that result in discontinuation of the drug. And this picture is mostly here to show you it doesn't matter which GLP-1 you use, they're all associated with these adverse GI side effects. But again, semaglutide more so than liraglutide and dulaglutide. And it's the most powerful for A1C and weight. It's also the most powerful in terms of side effects. And so when you're starting these medications, what I tell people is start slow, start low and go slow. So you're going to start at the lowest dose and give it 2 to 4 weeks. You want to make sure the patient's tolerating. And then once they're tolerating and not having any stomach effects, then you can go up to the real dose. So semaglutide 0.25 for 2 weeks and they're tolerating, then I can go up to my 0.5. If I go up to 1 and they develop stomach side effects, drop back down. Give them more time before you go up. Or consider switching to something maybe a little bit less potent, like a dulaglutide. And so if I get side effects at semaglutide 1, well, I could go down to semaglutide 0.5, or I can consider going to a dulaglutide instead and seeing if they could tolerate that. Or say I'm maxed out at dulaglutide 4.5 and they want more weight loss, or we need more A1C reduction, I could consider going up to semaglutide 2 milligrams. So you can kind of switch in between these based on the side effects your patient's having and their response to the treatment. Okay. Contraindications. Who should we not use these in? Really, that's people with a personal or family history of medullary thyroid carcinoma. And the reason for that is in rat models, there's been an association with medullary thyroid carcinoma. We have not seen this in humans, but it's still a black box warning. And so if your patient has MTC or a history of MEN2, that would be a contraindication. These are not contraindicated in papillary thyroid carcinoma or other kinds of thyroid carcinoma or thyroid nodules. Right? And medullary thyroid carcinoma is extremely rare. Thyroid nodules are really common. So you can still use these in people who have thyroid nodules. You may also want to proceed with caution if somebody has a history of pancreatitis. If they have gallstone-induced pancreatitis, status cholecystectomy, you can warn about the symptoms of pancreatitis and proceed. But if they have alcoholic pancreatitis that has been recurrent and they're still drinking, not a great choice. And then lastly, if they already have stomach issues, if they already have gastroparesis, or if they have IBD with constipation and diarrhea, you can talk and have a discussion about starting them, but you're going to want to go really slowly and have frequent check-ins on how their GI symptoms are doing. I have some people where they haven't exacerbated anything, and some people where they couldn't eat for a week after the first dose and they were just miserably ill. So it can vary. Now we'll talk a little bit about the 2 new GLP-1s. So this is our combo GIP-GLP-1 receptor agonist, GIP being glucose-dependent insulinotropic polypeptide, much easier to say GIP. And that's tirzepatide, or the brand name for diabetes is Mounjaro. The brand name for weight loss is Zepbound. So these are the names your patients will ask for. Comes in a pen similar to dulaglutide where you don't see the needle. So again, really good for people with needle phobia. And in red is what the GLP-1s do that we already talked about. In green, I want to focus on what the GIP does that's different. And so it acts directly on the brain to reduce food intake without the nausea that we see with GLP-1s. And so in theory, the GIP-GLP-1s are supposed to have less GI side effects than our GLP-1s by themselves and should be better tolerated. And so when we take a look at our tirzepatide data, what we see is, again, about a 2.1% reduction in A1C, which beats out semaglutide as the best of our GLP-1s. And then we have about a 14.7% reduction in weight, which beats out pretty much, again, semaglutide in terms of weight as well, and all of our other non-injectable weight loss medications. So we're really powerful for A1C reduction and weight. We do not have the cardiovascular outcomes data yet. Those studies are ongoing. So if your patient has ASCVD, you're probably still going to want to stick with Sema or Lira or Dula because we have data for that. The data for this just isn't out yet. And then they actually did a head-to-head looking at tirzepatide versus semaglutide and found that tirzepatide at all doses was more powerful than one of the highest doses of semaglutide. A1C reduction of another 0.2 to 0.5% and weight reduction further 2 to 6 kilos. And so even at the low doses of tirzepatide, we're more powerful than one of the stronger doses of semaglutide. Now, this is the one that we expect to come out next year, retatrutide, which is a combo GIP-GLP-1 glucagon receptor agonist. And again, GLP-1 is in red, GIP is in green, and my glucagon receptor agonists are in blue here. And so my glucagon receptor agonists are, again, acting on my brain to promote satiety and fullness and decrease food intake. But they're also acting on my brown fat to increase thermogenesis, and this contributes to increased weight loss. So they're really powerful and significantly stronger than my other medicines for weight loss. But because it's a glucagon receptor agonist, I am acting on my liver to increase glucose production. So they're not as great for glucose lowering. Much better for obesity, not as great for diabetes. And so when we take a look at this data, looking at retatrutide versus placebo, A1C reduction, I kind of fall out anywhere between this 1 to 2 range, depending on my dose, which kind of puts me on par with my stronger GLP-1s. But the big thing with retatrutide that's game-changing is here at 36 weeks is when they ended this study, I haven't plateaued in my weight loss. I've hit about 17% weight loss, which is fantastic and on par with bariatric surgery weight loss levels with a once-a-week drug, but I haven't plateaued. So we don't actually know what is the maximum weight loss somebody might get with retatrutide. Could we get 20%, 25%? We haven't studied it out far enough to know how much weight loss we're going to get, but this is really game-changing for obesity management. And so coming back to Mr. Snickers, we've talked about his cardiovascular, his CKD, his obesity. Now let's talk a little bit about costs, because this is something we should keep in mind as well. How do GLP-1s compare with some of our other medications in terms of costs? Well, they're expensive, right? And diabetes in general is expensive. The average cost or the annual cost of diabetes in 2017 was about $350 billion. 250 in direct costs, 100 in reduced productivity. And so if I use GLP-1s, I have a higher upfront cost, higher cost of getting this medicine because they're so expensive. But that is actually offset by less emergency room visits, less inpatient costs, less hypoglycemia. And so I actually am more cost effective using a GLP-1 compared with using even basal insulin. And so to prevent one death using GLP-1 compared with insulin, I save about $19,000. To prevent one hospitalization for hypoglycemia, I save about $10,000. And so they are, in fact, cost effective for the healthcare sector. So I hope by now I have convinced you that for Mr. Snickers, with his history of heart disease, his CKD, his obesity, his diabetes, that we should be sending him out on a GLP-1 receptor agonist, preferably semaglutide because it's going to be the most powerful for all of his comorbidities, but whichever one you can get their insurance to approve, or if you're a Grady and they have a Grady card, dulaglutide. That's what we have there. All right, Dr. McDowell, I will hand over to you.
All right, thanks so much, Dr. Markley. So Hugh gave a great review of all the GLP-1 agents and the approved indications, so type 2 diabetes, obesity, cardiovascular disease. But we know that this Ozempic frenzy is kind of everywhere at this point in time. So I'm going to spend the second half of this talk really discussing research into the other potential benefits of the GLP-1s. And keep in mind, none of these are actually approved indications for use of the GLP-1 yet, but we think that some of these will be coming in the next few years. So I'm going to start by presenting a patient that is probably similar to what many of you see in clinic. I have a 42-year-old Hmong male who presents just for his annual exam. And he has been struggling with his weight. It's been increasing over the past 10 years. His current BMI is 44.9. And this is fairly typical of the patients that I see in my clinic. He's met with nutritionists in the past, but hasn't found it helpful, mainly because he attributes that to cultural differences in his dietary habits and admits that his exercise is limited due to knee pain and deconditioning. So you're reviewing his labs and you see that his ALT and AST have been mildly elevated for the past few years. His A1C is at the upper end of normal, but because of these elevated LFTs, you calculate his FIB-4 score, which is elevated. So you refer him for a fiber scan, and he has F3 fibrosis. So what do you do now? So we know that he has risk factors for MASLD. Right now you've confirmed that he has liver fibrosis. Just a quick review about MASLD. As was mentioned, this is the new name for NAFLD. It's the most common cause of chronic liver disease worldwide and affects 1/3 of adults in the general population and actually 2 out of 3 adults with obesity and diabetes. And the main reason why we care about MASLD is because of the risk of progression to MASH and fibrosis and cirrhosis. And this is more commonly seen among people with obesity and diabetes. And since weight loss is the primary treatment for MASLD, it makes sense to wonder about the role of GLP-1s for this population. So Dr. Markley gave us a nice overview of the mechanisms of action of the GLPs. So she mentioned the weight loss, the improved insulin sensitivity, which obviously benefit the liver. The GLP-1s have direct effects on the liver. So the combination of all of this can lead to decreased de novo lipogenesis, decreased inflammation, and decreased steatosis, all of which can lead to resolution of MASLD. So I'm going to show you some of the data to support use in this population. First, with the Synergy NASH trial, which was published earlier this year in the New England Journal of Medicine. And this is a double-blind, placebo-controlled trial of patients who have a BMI 27 to 50 with or without type 2 diabetes and biopsy-proven MASH with F2 or F3 fibrosis. And these patients were randomized to tirzepatide. So remember, that's a GLP-1 GIP combination at varying doses from 5 milligrams to 15 milligrams weekly. And the primary endpoint that they looked at was resolution of MASH without worsening fibrosis. And that's shown on the left graph here. You can see that 10% of participants in the placebo group compared to 44% in the 5 milligram group, 56% in the 10 milligram group, and 62% in the 15 milligram tirzepatide treatment groups met criteria for this primary endpoint. So this was significant for all 3 of the treatment doses. The secondary endpoint, which was improvement of at least 1 fibrosis stage without worsening of MASH, was shown on the right, was not significant. So why is it that we might see resolution of MASH, but not improvement in fibrosis? There are some theories about this, but it is likely that longer treatment periods and follow-up are needed in order to see this improvement. So kind of similar to the idea that Dr. Markley presented, that longer treatment is needed in order to see the improvements in kidney function, or I should say the effects on CKD. We likely need that in the liver to see these effects. And in fact, if you look at the bariatric surgery data, this kind of supports the fact. In bariatric surgery, we see much greater improvement in liver fibrosis at 5 years post-surgery compared to 1 year. So do we have any data showing this long-term effect? Not so much at this point in time, but there was a recently published retrospective study from the VA, which looked at 14,000 patients with MASLD and type 2 diabetes. And these patients were treated either with a GLP-1 or a DPP-4 inhibitor. And they were followed for a 6-year period. So on this graph, we're looking at the cumulative incidence of cirrhosis. And you can see that GLP-1 use in this blue line was associated with a 14% lower risk of cirrhosis over the 6-year follow-up period. supporting again the notion that one-year studies may just be too short to capture the full effect of the benefits of the treatment with GLP-1s. And I don't have the data here, but this study also showed that all-cause mortality was 11% lower in patients treated with GLP-1s. So I think we have some compelling evidence here that treatment of moderate to severe fibrosis, that F2 or F3 fibrosis, can lead to resolution of MASH. And now we see decreased risk of progression to cirrhosis and actually improvement in mortality. So that's awesome. Both of these studies, though, looked at patients in MASLD without cirrhosis. What if your patient already has cirrhosis? And unfortunately, a lot of our patients are diagnosed in later stages of their disease process, and we may not capture them until they present with cirrhosis. So this study design, which was similar to Synergy NASH trial, enrolled patients with biopsy-confirmed cirrhosis and randomized them to semaglutide 2.4 milligrams weekly or placebo. And the endpoints in this trial were similar to the Synergy NASH study, looking at improvement in fibrosis without worsening MASH or MASH resolution. Now, unfortunately, there was no difference between treatment and placebo groups with regard to improvement in fibrosis, shown here on the left, or resolution of MASH on the right. So when I put all of this liver data together, and many other studies that I haven't presented, but it suggests that upfront aggressive treatment of this clinically significant liver fibrosis is really imperative, because this is when we can make a difference and prevent or delay the development of cirrhosis and subsequent complications. We currently don't have any treatments for cirrhosis aside from liver transplant, as you know. And so that's actually an area of interest of mine, is really how can we improve identification of these patients when we can actually make a difference and intervene. So let's come back to my patient. Again, he has F3 fibrosis. So he is at a stage in his liver disease where this GLP-1 may actually change his trajectory. Now, some of you maybe don't feel comfortable with these agents, are still doubtful about their benefit in this population. So if you're on the fence about this, let's look at some of the data on sleep apnea. So remember, he has chronic fatigue and snoring. He has not had a formal sleep study performed at this point in time, but you have a high degree of suspicion for untreated sleep apnea. So we do have some data looking at this, the SURMOUNT OSA trials published just a few months ago. And these trials, there were 2 of them, looked at adults with moderate to severe obstructive sleep apnea and obesity. Trial 1 looked at patients who were not yet treated with CPAP, and trial 2 enrolled patients who were on CPAP. And both groups were randomized, both trials randomized patients to maximum tolerated tirzepatide dose versus placebo. And the main outcome of interest in these studies was the change in the apnea-hypopnea index. So here on the left, we have the primary outcome. So we're looking at the changes, again, in the apnea-hypopnea index. The improvement was improvement of 25 events per hour in the treatment group compared to 5 events per hour in the control group. This is in trial 1. These are the patients who are not yet on CPAP, and similar findings were seen in the patients who were on CPAP. And these improvements correlated with significant weight changes, shown here on the right side. So I actually went and looked this up because I wasn't aware of what is considered a clinically significant improvement in the apnea-hypopnea index. And the American Academy of Sleep Medicine defines 2 thresholds. One is an improvement of 15 or more events per hour, or a decrease in events by 50%. And so in this study, we see an estimated treatment difference of 20 events per hour, or a 59% improvement compared to baseline. So this is really significant for our patients. And remember, some of these patients weren't on CPAP, so you're seeing this benefit even in people who aren't getting other treatments. So coming back to our patient, so he has obesity, he has MASH, He has obstructive sleep apnea, multiple reasons to consider treatment with a GLP-1. So what did I do for him? When I saw him in clinic, I started him on tirzepatide. Now, my decision for tirzepatide versus semaglutide really at the time was just based on availability. But I do tend to use some of these interchangeably unless there's a strong indication for one or the other. We started him on low dose, as Dr. Markley recommended, start low, go slow, and eventually increased him up to 5 milligrams weekly. He did have some initial modest weight loss just with medication alone, but this was really enough to motivate him to make more dietary changes. He started meal prepping, and he got really into it. He started his own 2-hour cardio program daily. So he's doing exercise, bike, treadmill, and then he loved going in the sauna as well. And at his 6-month follow-up, he had lost 70 pounds. So that's pretty remarkable. He's one of my star students. He has hepatology follow-up that's pending. He was formally diagnosed with obstructive sleep apnea, but actually never started on CPAP since his symptoms improved with weight loss alone. And so for him, what I opted to do at this follow-up visit is I kept him on the same dose of the tirzepatide. He hadn't plateaued yet in his weight loss, so I didn't feel the need to go up. But I did recommend for him that he add in some strength training. So he's had considerable weight loss, mainly cardio, but strength training I do feel is very important for these patients. So Dr. Markley mentioned the main side effect is GI, and I think a lot of us are aware of that. But there is some data looking at changes in skeletal muscle mass that can happen. And if you look, that's kind of what people are describing when they talk about Ozempic butt. They're just losing their muscle mass, okay? So there are estimates that suggest that patients may lose 25 to 40% of their muscle mass. And that's thought to be attributable to the magnitude of the weight loss rather than an independent effect of GLP-1s. Now, there is a question though, does this really matter? Are we maybe, even though despite the fact that we're losing lean muscle mass, are we improving the quality of the muscle that we have? A lot of these patients have myosteatosis, which is fat infiltration into the muscle, which is associated with adverse health outcomes, just like fat infiltration into the liver or the pancreas is. We don't really have the data looking to see if this improves, but we suspect that it would since we see this in other organs. And there's also some studies that have looked at the proportion of lean mass to total body mass and seen improvements. So even though we're losing muscle mass, that might not be a horrible thing, but I still encourage resistant weight training patients when they're on these medications. So just be aware of this. Do watch out for sarcopenic obesity, which can be worsened by weight loss with these medications. The other thing to be aware of is that weight regain, if you have a patient who stops a GLP-1, generally results in increases in fat mass rather than muscle mass. So you lose weight, you lose some of your muscle mass, you gain weight. Unfortunately, you only gain the fat mass back. You don't gain the lean mass with it. But there is some active research going on looking at different pharmacological agents that could prevent or mitigate some of this muscle loss. So just keep an eye out for those in the future. There's research into use of androgen receptor modulators and anti-myostatin agents as well. So that could be really exciting. All right, so in the last few minutes, I'll go through a few other disease states for which GLP-1 agents are being investigated. Several recent studies have looked at the risk of obesity-associated malignancies and GLP-1s. So there are 13 cancers that are associated with obesity, and those include esophageal, breast, colorectal, endometrial, gallbladder, stomach, kidney, ovarian, pancreatic, thyroid, hepatocellular carcinoma, meningioma, and multiple myeloma. So this was a large cohort study that included 1.6 million patients with type 2 diabetes who were treated with GLP-1 receptor agonists versus insulin. And you can see that GLP-1 was associated with significant risk reduction in the majority of these cancers, 10 out of 13. There's no difference seen in the rates of breast cancer, stomach cancer, or thyroid cancer. And another study also recently put out by the American Society of Clinical Oncology this year evaluated a global healthcare database to compare patients who were treated with GLP-1 bariatric surgery versus controls. And these were obese patients, BMI greater than 35. And they found that patients who were treated with a GLP-1 or bariatric surgery had reduced risk of obesity-related cancer compared to no intervention, with a hazard ratio of 0.61 and 0.78 respectively. You can see that patients lost more weight after bariatric surgery, but despite this, it was a GLP-1 use that was associated with superior all-cause mortality. So this is now the second study that I've shown you that has demonstrated a significant reduction in all-cause mortality associated with patients treated with GLP-1. Okay, shifting gears again, what about alcohol use disorder? So this is a problem that affects probably a number of your patients, and it's associated with more than 80,000 deaths annually. There's a lot of preclinical rodent data that suggests that GLP-1 agents may reduce drinking and alcohol relapse, and this is thought to be mediated through the effects of GLP-1 on the ventral tegmental area and nucleus accumbens area, which are key areas that are involved in dopamine signaling and reinforcing effects of food and alcohol. So to investigate this effect in humans, this group looked at 80,000 plus patients who had obesity, no prior diagnosis of alcohol use disorder. These patients were all prescribed either semaglutide or a non-GLP-1 weight loss medication and followed then for 12 months. And compared to non-GLP-1 agents, semaglutide was associated with a significantly reduced risk of alcohol use disorder diagnosis, 0.37% versus 0.73%. And you can see that these findings were consistent across gender, age group, race, and independent of diagnosis of diabetes. The same group looked at a subgroup of patients who were treated with naltrexone. Some of you may be aware of Contrave, which is a weight loss medication that combines Wellbutrin and naltrexone. And even when comparing semaglutide to naltrexone, this positive benefit with semaglutide was seen. And I find that to be particularly striking since naltrexone is actually one of the agents we have approved for alcohol use disorder. The same group again also looked at patients who had a previous diagnosis of alcohol use disorder and looked at recurrence and found that semaglutide compared to non-GLP-1 obesity medications decrease the risk of recurrence in patients with a previous diagnosis of alcohol use disorder. And then finally, one last problem of interest that I frequently see in my own clinic for medical weight management is post-bariatric surgery weight regain. Now, this is a common problem that affects at least 25% of all patients who have gone through bariatric surgery. And the absolute numbers on this are really hard to quantify given various definitions that are used in some of these studies. But just to demonstrate this to you, this graph here is from the Swedish obesity study, which is one of the longest bariatric surgery studies that followed patients for 10 years. And on this bottom red line here, you can see that patients who underwent Roux-en-Y gastric bypass reached their nadir weight loss at 1 year, and then kind of experience steady weight regain in the years that follow. And this has been shown in a lot of different studies. So it's clear that we need some strategies to manage this weight regain, or even to help patients who maybe have suboptimal weight loss immediately following surgery. And this is an area of active interest, but this is a small retrospective study that looked at 44 patients with post-bariatric weight gain who were treated with semaglutide. And they looked at patients who had both sleeve gastrectomy and Roux-en-Y. And you can see that after starting on semaglutide, they had significant weight loss as soon as 1 month after starting on treatment. And the average weight loss at the 10-month follow-up was 10.3%. So while more research definitely needs to be done in this area, I could definitely imagine a future where our patients may be managed with some combination of GLP-1 and surgery to help promote long-term weight management. And now we could go on for hours talking about all the other studies that are going on with GLP-1s, but just so you guys are aware, some other areas of active investigation include research into Parkinson's disease, Alzheimer's disease, depression, PCOS, smoking cessation, opioid use, and glaucoma, just to name a few. So to wrap up, I want to encourage you all to feel comfortable using these agents in the appropriate patients. This claims database study of 156,000 patients with diabetes and established cardiovascular disease evaluated the use of statins, ACEs or ARBs, and SGLT2 or GLP-1 agents. And these are all agents that would be indicated for these patients based on current clinical guidelines. And unfortunately, you can see that over 1/3 of these patients were on no agents. 40% were treated with one agent, 19% were on two agents, and only 2.7% of patients were on all three of these agents. And if you look to the right, you can see that of those that were on treatment, the majority, or 53%, were treated with an ACE inhibitor. 25% were on a high-intensity statin, and only 10% were on an SGLT2 inhibitor or a GLP-1, and they didn't break these out separately. But to me, this suggests that there are alarming gaps in the use of evidence-based therapies, even among these insured patients who have type 2 diabetes and established cardiovascular disease. So my take-home message is that while GLP-1 receptor agonists may not be the panacea for all ailments, there's certainly good data to support their use in patients with type 2 diabetes, obesity, MASLD, and sleep apnea. And emerging data will likely support this use in other populations as well, I suspect. Now, there are certainly side effects to be aware of, but please don't shy away from using these agents in the appropriate clinical population because you can really make a difference for patient outcomes. So thank you very much, and we're happy to take any questions that you guys have.
Fantastic. Thank you all so much for a phenomenally informative presentation. And we have tons of questions in the chat, and I'm going to try to get to all of them. I think we might be able to. So, and please continue to put your questions in the chat. Some of the early questions were talking a lot about insurance approval. And I guess a way to sort of approach this is, Ali, especially what you presented was very much a metabolic view of the role of these medications. And so as you think about this, it is a little bit different in the way that we think about how to approach the care of these patients. So could you help us to understand when you are thinking about a patient like this, how do you envision specialists and general medicine physicians partnering on patients' care, number one? Number two, how best, in your experience, can we appeal to insurance companies to have these medications approved? And yes, there's an early comment about how, if insurance companies had the long view, they would fund these medications, but many times short-term profits take precedence. And it's very difficult to get these medications and practice the evidence-based medicine that you're advocating for. So help guide us to make some of those decisions.
Okay, so maybe I'll start with the insurance question first. So I am fortunate now to be at the VA, where we have some of these agents on formulary. We do have a strict tiered system that we need to adhere by that was put in place due to the shortages of these medications, right? So that could be a whole nother talk about how do you prioritize who should be on these medications. But at the VA, we're pretty fortunate about being able to get these medications for patients who really need it. My approach when I was practicing at Midtown was to talk to patients about all of their weight loss management options. So not only the GLP-1s, because I recognize that not everybody has coverage for that. But then I would usually task the patient to go to your insurance company and find out what is covered, okay? Instead of just sending things willy-nilly, because you will drive yourself crazy trying to do all of that and then have very little success with it. So frequently, you can find actually that there is a GLP-1 that the patient's insurance may cover. And a lot of this will depend on other comorbidities. If they have type 2 diabetes, you're almost certainly set and you can use these. That's pretty widespread coverage at this point in time. Even Medicare now covers weight loss GLP-1s for patients who have established cardiovascular disease. So that was huge when Medicare started to approve these medications, and a lot of other insurance companies will follow along. Some insurance companies will require patients to try and fail other obesity medications first, in which case, you kind of have to play that game and go through the process. A lot of the other ones are either harder to tolerate or not as efficacious. So generally after a 3 month trial, if they haven't lost 5% of their body weight, you can say that they failed them and kind of go up next in line. In terms of primary care and specialty management, I mean, I want you guys to feel empowered. If you have a patient with type 2 diabetes, go for it. We don't need to be the ones who are prescribing this. And unfortunately, we see a lot of people who come to us on basal bolus insulin who've never been prescribed one of these, and we're able to potentially get them off all insulin because of how effective some of these medications are. I work very closely with the liver clinic here, and so they refer patients to me directly who have fibrosis in that stage 2 or stage 3. So we have more of a multidisciplinary approach that we take with some of those patients, which I think a lot of institutions are going towards as well.
Thank you so much for that. So a couple of other questions that I think we can kind of lump together. What do you counsel your patients on in terms of duration of therapy? Is it lifelong? And if not, how do you know what to do?
I tell them, you're going to be on this, right? It's like when you have high blood pressure and you take thiazide. You have well-controlled hypertension, but the moment we stop this, it's going to come back. And so it's the same with these GLP-1s. It's going to help with the weight loss. It's going to help with the diabetes. It's going to help with the MAD but the moment we stop, it's going to come back. And so I tell them, plan that you're going to be on this for forever. Now, there are some patients that I've had who've lost a ton of weight and their A1Cs are down at 5.7 and they're wondering, should I back off? Should I stop? I usually recommend no. If we're holding and we're doing well, continue. If your patient is really worried, or usually it's more like the patient's your wives are really worried about how skinny they've gotten. We can try a lower dose, but if I start seeing that A1C come up or your weight starting to go back up, we're going to bump you right back. So I tell people, I don't expect you to come off of these if they work well for you.
I generally take this approach.
I'm sorry, go ahead, Allie.
I was just gonna say, I generally take the same approach. We know that when people stop these agents for weight loss, that they tend to regain the weight. Now, the longer term studies suggest maybe they don't regain all the weight, so there may still be some kind of more legacy type effect, but there is significant weight regain generally when people stop these medications.
Okay. And so with that, and with a growing cohort of patients that may be on longitudinal therapy, what other longitudinal health maintenance issues do we need to be thinking about? Shanti, for example, is asking about the muscle mass loss, reduced bone density. Is there a different algorithm for monitoring that, and other things that we need to be paying attention to?
So very, very good questions. I don't think we have any formal guidance regarding those kind of more longer term outcomes right now, since a lot of these medications, even though they've been around for years now, are still, fairly novel in the diabetes and definitely in the weight management world. But the muscle mass I talked about, we did not touch on potential increased risk for bone loss and osteoporosis. You can see that with any type of weight loss, so that may not be a specific GLP-1 effect, but those kind of longer term conditions are definitely things that you want to be aware of. But make sure you're doing your general osteoporosis and DEXA screening in patients who it's indicated for and that type of thing. So you want to continue all of your other kind of routine preventative care for sure.
The strength and the weight training that Ali talked about can really help for the muscle mass, but also the bones too. So encouraging that weight bearing exercise is going to help with your osteoporosis prevention, just like it would in anybody.
Great. Thank you. And Ted and Carlos, I see you guys are on. Do you have a question or just being a receptive audience?
Both. The expression of start low, go slow, we modified in geriatrics to start low, go slow, but get there. Is there any evidence that people who are starting low and going slow never get to a therapeutic dose? Thanks.
Not that I'm aware of. I have seen patients who've been referred to us after being months on 0.25 of semaglutide because somebody just forgot to bump them up. But usually, somebody, either a pharmacist or insurance, is like, hey, what is happening here? Your patient isn't on a real dose of semaglutide, and we need to make a change. And so patients themselves are also pretty savvy. And so they're aware of all of the benefits, mainly the weight benefit. And so I'm usually finding that I'm getting requests to increase the dose sooner. Like they've been on it for a month, their visits in 3 months. They go, hey, here's my numbers. Can I just bump it up now? And you're like, yeah, because you can bump up as early as 1 month, from like 0.5 to 1 to 2. You can go up every month. So I'm usually finding patients are actually asking to go up in between visits before I've even seen them back.
Karen, this is Carlos. Thank you very much. This was a fantastic grand rounds, and I learned a lot, and I really want to commend you on anchoring on patients, because I think it's so much better for us to understand when you think about a patient and you think about how you're going to use a drug on a patient. So really very, very nicely done. I think there's a lot of things we still don't know with these drugs, and my question to you would be, what do you think are the sort of the big research priorities that we need to pay attention to?
So I think that probably, at least from my perspective, has to do with all the metabolic things that I was discussing. So I think that MASLD and MASH are a big area. We just recently have had medication approved for treatment of MASH outside of the GLP-1 realm. But prior to that, it was all weight loss, weight loss, weight loss, right? And so the more agents that we can use, I think the better for treating these patients and preventing this unfortunate trend towards cirrhosis, hepatocellular carcinoma, liver failure requiring liver transplant. So from my perspective, that's what I'm most interested in. Some people who deal more with addiction may be interested in the opioid use disorder, right? So there was actually a recent study that just came out within the past week or two suggesting that patients with diabetes who are on semaglutide have a lower risk of opioid overdoses compared to patients on other agents. So is that a direct correlation, causation? I don't know what that is, right? But there's a lot of research going on in the realm of addiction as well, which will probably make a big difference for our patients. So I think lots of different areas. I'm not sure that I can just pinpoint one.
But for maybe you in particular, Dr. Del Rio, if you have any fellows who would be interested in looking at HIV-associated lipodystrophy and GLP-1s, that could be a really fascinating area.
And I think that's a very interesting area.
Okay, so it is right at the hour, but I don't want to, if you guys can stay for just a few more minutes, a lot of questions about what we should think and tell our patients about compounded medications if they're not able to get medications from the pharmacy.
No.
Just no. Can you tell us what to say? Tell us what to say.
That it's a risk, right? We don't know exactly what these pharmacies are compounding with. We don't know what else is in there and what effects that this might have on them. So we'd like for them to use the brand names from the pharmaceutical companies because we know exactly what it is, we know what to expect. And by and large, for things like Ozempic, the shortages have resolved. Mounjaro or tirzepatide is still hugely backordered. If you're going to use a compounding pharmacy, I do not. I don't think Dr. Migdal does either, but I do know that there are some endocrinologists who have done a lot of research into the compounding pharmacy that they use. But I also heard that because the back order is going to be gone, companies are going to start suing compounding pharmacies because there won't be a shortage anymore. And so patients are starting to not be able to get them from compounding pharmacies anymore either. But typically we recommend no, just because you don't know what it is and you're injecting it into your body, you want to know what it is.
Yeah, aside from the fact that there's no type of regulation over this thing, and so you don't know what you're actually getting, There's reports of the dosing being confusing for some patients. They may have vials and syringes, or they may not understand exactly how they're supposed to use it. And so patients are presenting to the ED with overdoses, if you will, of semaglutide that can present as extreme constipation, vomiting, things like that. So it's not only we don't know what you're getting, it's that patients often don't know how to take it appropriately.
Super helpful. So message is no, but also know and be patient. The shortages may be resolving soon, and therefore, why would you do it the other way since we don't know what's in it? Thanks you. Okay, one last question from the Grady resident group. And as they do their due diligence in reviewing patients' histories, and we're asking our patients, do you have a personal or family history of medullary thyroid cancer? Do you have any tips from endocrinology about how to distinguish a history of medullary versus papillary thyroid cancer in patients who report it?
Yeah, right. The generic, yeah, somebody in my family has thyroid cancer and I don't know anything about it. So most commonly it's going to be papillary thyroid carcinoma, but knowing about family history, if it's multiple people or multiple generations in a family who's had thyroid cancer, that's pretty atypical for papillary thyroid carcinoma, not usually familial. So if they've had multiple people in a family, you could also consider asking about some of the other conditions seen in MEN2 to see if those run in their family to see, okay, does maybe they have an increased risk here. But I think by and large, you can do some heavy counseling of, well, we don't really know what kind of surgery or cancer your family had. Most likely it's papillary, and risk benefit discussion about whether to start. But I don't think if they don't know and their family doesn't know, there's not a great way of getting that information out of them.
Sometimes I'll ask if they do know more about the type of treatment that the patients had or their family members had for the thyroid cancer. If they had a hemithyroidectomy and that was it, it's much less likely to be medullary thyroid cancer versus if they say, oh, they had their whole thyroid out, they were seeing the oncologist, they got chemotherapy and that type of thing. Okay, that's probably not just papillary thyroid cancer.
I think Dr. Goebel had a question that we should probably address about the anesthesia recommendations about GLP-1s in the peri-op period. Of note, that society guideline has no endocrinologist on it. And so what they have recommended is for the weekly GLP-1s, you hold them for 1 week prior to surgery. And for the daily GLP-1s, you hold them for 1 day prior to surgery, which, as Dr. Goebel pointed out, makes no sense from a pharmacologic or physiologic perspective. The half-life of the weekly GLP-1s is about a week. So if I have you on semaglutide 2 milligrams and you hold it for 1 week, you're still going to have semaglutide 1 milligram in your system. So why is it not safe to proceed for my patients on semaglutide 1 milligram weekly? So it doesn't make a lot of sense from a pharmacologic perspective, nor from the main problem, because you're still going to have GLP-1 in your system, which is slowing down the gastric emptying. And that's what we worry about, right? We want you to have an empty stomach when you're going into surgery. So there have been a few studies that Dr. Migdal had looked up that show you need longer fast.
Mm-hmm.
And so it's not necessarily the holding of the medication. Sure, go ahead. Holding 1 dose of semaglutide isn't going to hurt anything. But I tell all my patients that I want you to fast for longer. You need a longer period of NPO before you go into the OR to ensure that your stomach is empty when you go under anesthesia.
And there's actually a recent just retrospective study that looked at patients who are undergoing endoscopy, colonoscopy, or both simultaneously. And there is an increase in the retained food products that they see in endoscopies. But when they looked at patients who underwent colonoscopy and endoscopy, they didn't see that. So the thought was, okay, maybe these patients have a longer period that they're NPO or they're on liquids, right, for the day before. So they're just clearing all of that. So coming back to Dr. Markley's point about probably a longer NPO period is really more important than how long you hold the actual medication.
Fabulous. All right. It is 1:06. This may be a record that at 1:06, we still have 106 participants. I saw the number actually go down and then go back up. So people like left and came back. Thank you so much for a phenomenal presentation again and for answering so many questions. We will all go forth and bravely prescribe these medications, these game changer medications. Thank you so much. Y'all have a great day.
Thank you for having us.